All right, so this is the fourth in the series in the cardiovascular system, the fetal to newborn circulation. A lot changes with birth, and I'm going to go through the importance of newborn resuscitation. And in the process of explaining fetal to newborn circulation, you're going to learn a lot of anatomy and certainly some physiology. So at fetal circulation before birth, the heart is a single heart pump. Instead of the right side and the left side of the heart, it's a single pump. And persistent fetal circulation is the name that is given to a child, a baby, that structures fail to close. And again, we're going to talk about how important it is to get a really good deep breath at birth. So the things that are specific to the baby, a single pump in utero, and closing, and all those structures that close upon with good lung expansion. So we're going to talk about what happens with birth and cutting the cord. First question, circulatory structures are open to maintain a single pump before birth or in utero. How many structures close at birth? And this is a depiction of all the different structures within the fetus. Is it one structure, two structure, or three structures that close at birth? And the correct answer is throughout the body of a baby, of a fetus, actually three structures close at birth. Two of those structures are within the heart. The third structure is the ductus venosus, and that is at the site of the liver. So in order to create the double pump, two structures, the foramen ovale that's within the atrial septum, and the ductus arteriosus that is present between the aorta and pulmonary artery, those are open in utero. So the image on the left showing the baby in utero is where the fetal circulation is including the placenta, the umbilical arteries and vein. So notice if you can see where there's two arteries coming from the baby of relatively deoxygenated blood, and then coming away from the placenta, the baby's picked up blood, oxygen, and delivering that to the heart, and then pumping it throughout the body. On the right side, after birth, with the cutting of the umbilical cord, those vessels spasm down, the umbilical vessels spasm down, and then the lungs take over the work of oxygenation for the entire body. So then fetal circulation with a single pump is a low pressure system, and everything is growing equally. So the umbilical vein is supplying the oxygen, and then at birth, the circulatory patterns change. And it's that first breath and that inflation that closes a lot of shunts and is critical for the transition from fetus to newborn. The placenta is really amazing, and it's growing so rapidly early on in pregnancy, but it's only there for 9 months. So after, like 40, 42 weeks, the placenta starts to deteriorate. So they, even though maybe the baby could stay in the mother longer, obstetricians get kind of anxious about allowing a mother to go too long in their pregnancy because the placenta fails after 9 months. Notice this is the baby side. The shiny side is the fetal side. And although the vessels are very close to the surface, the baby's blood doesn't mingle, I should say, with the mother's blood. So a diffusion gradient is what carries the oxygen and carbon dioxide across the very thin membranes of the placenta. And a diffusion gradient, if you remember, is where molecules from a high pressure or higher concentration move to a lower concentration. So it's pretty easy for carbon dioxide to just diffuse using the diffusion gradient. So this is the baby side, the mother side, and as the placenta, as the baby's blood passes by the placenta, carbon dioxide diffuses across to the mother. So that's how CO2 works, but there is no diffusion gradient for oxygen. So your options are, is the fetus stealing oxygen from mom, or is the baby absorbing oxygen from the amniotic fluid? The answer is it's stealing. Already it's being very greedy to mom. Now, just a reminder, hemoglobin, the hemoglobin molecules are within the red blood cells, and their function, at least the iron in it, is to attract oxygen and bind oxygen. With fetal hemoglobin, it's a little different. Fetal hemoglobin has a higher affinity for oxygen. And so that middle image is the oxyhemoglobin dissociation curve. So the fetal red blood cells are clinging on to oxygen stronger than adult or newborn, or after the conversion to adult hemoglobin. So it's able to take oxygen away from mom. So another depiction showing the mom's heart delivering oxygenated blood to the placenta, and the umbilical artery passing on the other side of the placenta, on the other side of the barrier. Relatively deoxygenated blood is passing by and picking up oxygen with that fetal hemoglobin and delivering it to the fetus through the umbilical vein. Did you notice, why is this vessel shown by the yellow arrow called an artery when the blood is deoxygenated blue? This is following up from our talk about the pulmonary circulation in the last talk. So is it a misprint, or the blood is coming from the baby's heart? The right answer is it's an artery because it's coming from the baby's heart, although it is deoxygenated blood. So remember, a vessel is that general term, transports blood. It could be arterioles, veins, venules, capillaries, or even lymphatics. So it doesn't matter whose heart it's coming from, even though the little fetal heart might not be generating a lot of pressure, it's still called an artery. Okay, next question. The fetus is not genetically identical to the mother. It's got half the genetics from the father, so it could have a different blood type. Why doesn't the mother's immune system reject the fetus? Is it because the mother's immune system is depressed during pregnancy? Or is it that large particles cannot cross the placental barrier, or both? And the answer is both. This is one of the reasons why it was so much a concern about pregnant mothers being sicker with COVID-19, because they do have a depressed immune system. And we'll talk more about ABO and Rh incompatibility when we get to the immune system. But basically, for these larger immunoglobulins, AB immunoglobulins, they cannot cross the placental barrier. The case presentation is about a baby girl who was born in rural Utah in 1927. A very small hospital, only a doctor and one nurse were taking care of the mother and baby. And the mother started getting into trouble, started bleeding. The baby was set aside to care for the mother, and didn't cry, so they assumed perhaps the baby was dead. The mother was quickly stabilized, and a little bit later, when the nurse went back to look at the baby was noted to still be alive. And what the baby ended up having later was a patent ductus arteriosus, where a part of her fetal circulation persisted. And her patent ductus is between the aorta and the pulmonary artery. So this is a persistent shunting or mixing of oxygenated and deoxygenated blood. So that mixing causes abnormally low blood oxygen content, and the heart is having to work very hard to deliver what little oxygen it has to all the tissues. So this little girl, Lenora Bowen Skidmore, at that time in 1927, there were no treatment options. She, at age 10, had a very activity was severely limited. And they thought, well, maybe if they sent her away to someplace in California, the milder climate would be better for her heart. And this is with her uncle. In 1947, at age 18, she's still alive. She goes to college at age 18, and she marries this gentleman, Bill Skidmore, a World War II veteran. And their first child also has a persistent fetal circulation, a PVA. And in 1952, finally, a cardiothoracic surgeon comes to Utah and does the very first open heart surgery on both mother and daughter on the same day. And this image shows what they did, where they took a tie and tied it over the shunts right here. They put a tie and just tied it off. And this is the news article, repair, and showing her mother's now age 24 and baby is now age 4. So Lenora Bowen Skidmore goes on to deliver 5 more children. The other 5 children did not have any heart defects. So a total of 3 daughters and 3 sons. And these are her daughters to the right. And this is the daughter now in this image in 1960, age 65. Mother's now, Lenora's now 86, and another daughter, and the 2 ladies at both sides flanking are granddaughters. As a matter of fact, this is me, and these are my 2 daughters on either end. And this is up in northern Utah running an epic relay race. She's not running, of course. She's a sponsor. So Lenora Bowen Skidmore lived from 1927 to 2017, 20 of those years with persistent fetal circulation. She had a repair after the first child, and she died at age 89. Okay, so let's go through a little bit more about fetal circulation, and then we'll come back to why her first child would have a PVA, or persistent fetal circulation, patent ductus arteriosus. So what's the advantage of having this single heart pump during fetal development? Is it A, equal mixing of oxygen in a single chamber, B, equal distribution of oxygen to all growing tissues, or both? And the answer is both. So before birth, you've got a single heart pump, and that allows oxygen to go to all tissues. Since the lungs are not functioning, they're just growing, you don't need all your oxygenated blood to go through the lungs. After birth, it switches to this double pump. So all of the deoxygenated blood coming from the body goes through the lungs to get oxygenated. And it separates, those shunts close in order to separate the blood from oxygenated to deoxygenated, or from oxygenated. So what is the physiology of closing the shunts at birth? Is it lung expansion? Is it cutting the umbilical cord, or both? And the answer is it's actually both. The first breath and cutting of the cord drops the pulmonary vascular resistance. Taking that first breath and breath expansion drops pulmonary vascular resistance, and those pressure changes stop the flow of blood from going across the foramen ovale between the atria. And the ductus arteriosus spasms down and shuts off because the placenta delivers prostaglandins that help to keep it open. So before birth, you actually have two valves in your right atrium. Besides the tricuspid valve between the right atrium and right ventricle, there's the foramen ovale. So blood can go in through either of those, or in fact goes through both. And that's what the foramen ovale looks like on the image. It's that one-way valve. And when the lung expands, left atrial pressures become higher than right atrial pressures because the pulmonary vascular resistance drops. And as that pressure is higher in the left atrium than the right, that eventually, without blood going through that valve, it seals down. But it doesn't, it eventually seals, but there's a 10% of the population where there is it's called a probe patent foramen ovale, where during heart surgery, sometimes the surgeons will take a probe and just check it, and they'll be able to push the probe across through that tunnel, and they'll just put a little stitch there. But the problem is with having the potential opening there, you have to be really careful about like air in the IV lines on those particular patients, or with newborns, because if they cry or bear down, they can increase pressures on the right side of the heart, and that little bit of air can go across the valve, and you can potentially get a little air embolus into the brain. So the caution is to avoid air in IV lines, especially in newborns. And you can see that with crying. So before birth, a single pump, the placenta is also delivering these prostaglandins. Prostaglandin E2 keeps the ductus arteriosus open. And then cutting the cord makes it spasm down. And if you can see, this is the ductus arteriosus right here, this blue between the pulmonary artery and the aorta. And after cutting the cord, cutting off the prostaglandins helps to spasm that down and close that shunt. So before birth, you've got one umbilical vein carrying oxygenated blood from the placenta to the baby's heart. And then you have two umbilical arteries carrying deoxygenated blood back to the placenta. So if you look at a cross section of the umbilical cord, it'll look like a smiley face. The two arteries, and you can remember the arteries because they're thicker walled, got smooth muscle, and there's one vein. Good to know in case you have a baby that's born having difficulty, can't get an IV started. These umbilical vessels may stay open for a short time after birth. So if you need to give fluids, glucose, medicines, you can actually use the umbilical vessels after delivery for a short time. Currently, there are easy treatments. So you can either do a coiling where you don't have to go into surgery and have open heart surgery, and they can thread a catheter in the right side of the heart through the pulmonary artery and put a little coil that helps to block off that pulmonary artery. Before they would do that, though, they would use antiprostaglandins, and things like Motrin, Aleve, all of those are antiprostaglandins. And those are given within 10 to 14 days after birth. And this is the reason that obstetricians tell pregnant women that they would prefer they do not take things like Motrin, Aleve, because of this antiprostaglandin effect of those medications. So what situation is likely to cause an infant stress and make it less likely to take a deep breath after delivery? Be maternal bleeding, a maternal illness, extended labor, or all of those things? The answer is all of those things. Basically, it takes a lot of strength to blow up a balloon, which the alveoli are for the very first time. So it takes a healthy newborn to inflate their alveoli, to inflate their lungs. So you can expect that you're going to have a quote unquote depressed newborn if it's a prolonged labor. It's really hard on the baby because every time the uterus contracts, the baby does not get flow to the placenta. So drugs given close to delivery can depress an infant. If there's an infection in the amniotic fluid, or if there's an illness in the mother, for instance, a mother like my mother who had persistent fetal circulation herself, she had poor oxygenation. And that was depressing the infant. So illness, anemia, all of those things you can expect a depressed newborn. And that comes down to why it's so important to make sure within that first minute, babies get lung expansion. And this is resuscitation. This is a resuscitation actually in Uganda. So this is a baby born C-section, had a prolonged labor, and wasn't breathing. And this is a clamp. This blue is a clamp across the umbilical cord. So the WHO, the World Health Organization, along with the Pediatric Society, came up with this chart that is printed out and is placed in as many clinics as possible to go through the scenario of how to resuscitate a baby. And the golden minute, that's the first minute, is where it's important to stimulate the baby, get the baby crying. And then if within that first minute the baby is not crying, not breathing, it's to go ahead and initiate ventilation with a bag mask. And this is one of the PA students performing bag mask or showing bag mask resuscitation with little mannequins. and the nurses and nurses' aides learning newborn resuscitation. And along with that is community health training. These are all midwives that are delivering and taking care of babies in the the communities around these medical units. And many times, especially in the rainy season, it is impossible to get mothers to these clinics for delivery. So these men and women need to know how to safely deliver a baby and when to refer them during pregnancy. And this is a chart that was created by a student at Roanoke College, the danger signs of when to refer mothers. So in summary, fetal circulation and newborn circulation. In the fetus, it's a very low pressure system. Everything is growing. Deoxygenated blood is coming from the upper body, mixing with oxygenated blood from the placenta, and all this blood is being mixed equally. So everything is growing. In utero, at birth, in the heart, two of these shunts close at birth, the foramen ovale and the ductus arteriosus. And if there's a problem, the baby doesn't breathe, it becomes persistent fetal circulation. And some of those shunts may not close down, and that mixing will cause poor oxygenation of the baby. So a total of 3 shunts close at birth. This is very rare for this ductus venosus to not close, but that will cause medical problems as well, and problems with the liver if that doesn't close at birth. So most importantly, upon birth, a baby must be able to take a deep breath, must be able to oxygenate its own tissues through the lungs, detoxify its own blood through the liver. Any questions, please leave comments in